Maybe you notice them with dry skin or real pale skin. They don't quite look like themselves. You might notice a difference in cognitive or physical function. They're not getting around as well. Maybe they have a wound that's not healing. So it might be more than just that weight loss.
Hey out there, welcome back to the Nursing Home Abuse Podcast. My name is Rob. I'll be your host for this episode. We are talking all about preventing malnutrition in nursing homes, what malnutrition is, what it does to the body, and the things that we can do to lessen the likelihood that the residents will get it. But we're not having that conversation alone. We have the fantastic Dr. Lisa Moloney on to walk us through that process. But now it is time for the Nursing Home Regulation Question of the Week and another opportunity for you to win the Nursing Home Abuse Podcast coffee mug. It is the perfect vessel from which to drink your morning brew or tea. Hot tea is something that also drinks well out of this thing. How do you win it, you might ask? Well, it's extremely difficult, at least in my experience. You're going to go to our TikTok, which is @JusticeForResidents. You're going to find the Question of the Week video for this week, which you're going to be looking for the thumbnail that has an Ewok on it from the Star Wars movies, the Ewok. Look for a little furry alien. You're going to click on that thumbnail. You're going to comment your favorite Star Wars movie, and also the answer. And that's going to enter you for your chance to win the Nursing Home Abuse Podcast mug. My favorite Star Wars movie is Return of the Jedi. And that's because I actually saw that movie in the theater. I think I was maybe 4 or 5 years old. So it was, I think, my first movie actually. And the line wrapped all the way around the building. It was like the most exciting thing that's had ever happened to me in my life. But Star Wars Return of the Jedi, favorite movie. You thought it was going to be Empire Strikes Back, but it's not. Maybe yours is, what is it? Rise of Skywalker? Maybe it's Phantom Menace. Maybe you're of an age where Phantom Menace is your favorite one. Whatever the case is, indicated on the TikTok. A random winner will be selected on Sunday and announced at schenkfirm.com/podcast/giveaway. And the prize is shipped at the end of the month. I never liked what George Lucas did to Return of the Jedi. He changed the Jabba's palace scene with the musical number and made it super cornball. And I don't think I could ever forgive him for that scene at all. That's out of all the things that he did to change the original trilogy, that to me burned my toes the absolute most. Difficulty level this week, folks, I'm going to say is fairly easy. So if you get this correct, go hug the closest Ewok. Under 42 CFR 483.75, what must a facility do with its QAPI plan once it has been developed? Is it A, submit it to Gandalf the Grey, B, file it with the Centers for Medicare and Medicaid Services within 30 days, or C, present it to the State Survey Agency annually or upon request? And that answer is C. Once the QAPI plan has been developed, it must be submitted to the that state's survey agency annually or upon request by the state surveyor. All right, folks, now it's time to get into the meat and potatoes of the episode. And I think this is maybe the first time we're getting into the meat and potatoes of the episode is the most apropos. I don't know if I feel comfortable saying apropos, but I'm going to leave that in there. Anyway, malnutrition and nutrition is the subject matter for today. And again, as I mentioned, we're not having this conversation alone. We have Dr. Lisa Moloney on. Lisa is a nutrition researcher specializing in evidence-based practice. At the Academy of Nutrition and Dietetics, she develops clinical guidelines that translate research into actionable strategies for healthcare professionals and policymakers. She earned her PhD in health science from Northern Illinois University, where she studied dietitians self-efficacy and evidence-based practice. We have to make these bios easier for me to say. Dr. Moloney lives in Southwest Chicago with her husband and 3 children. We're so happy to have her on the show this week. Lisa, welcome to the show.
Thank you so much for having me.
I want to kind of set the table for the episode because we're going to definitely talk about what your research has shown, but I want us to be on the same sheet of music. When we say the word malnutrition, what are we talking about?
We're talking about the consequences of inadequate calorie and protein intake, and it could also be due to other factors such as inflammation that can be caused by acute or chronic disease. So it can be a multitude of factors. So not only intake, but what also is going on with the human body and the consequences that are associated with malnutrition. So it could be loss of physical or cognitive function. It could also be increased risk of morbidities and mortality, and also an overall impact on quality of life.
So it's not just the compromise in the intake or the deficiency of intake. It's the actual symptoms that or the ramifications of that as well. That's malnutrition.
Yeah, absolutely. So inflammation has a whole bunch to do with it as well, because it increases your calorie and protein needs. It changes how your body uses your calories and your proteins. So, I mean, it's a whole system of factors at play.
So why would the elder community or the typical residents of long-term care be more susceptible to malnutrition than other populations?
Well, it could be once again, we have a lot of factors going on. So, you're possibly in a new place. You're not getting, the food and the nutrition that you might be used to at home. At older ages, you might have additional comorbidities such as diabetes or hypertension, and that could, impact your appetite or how your body metabolizes foods. It could also be polypharmacy. So you might be taking some medications that change the way food tastes. It could change your appetite. So among all those factors, it can really reduce your calorie and your protein intake and increase your needs.
I
Not
think
to mention your food's different.
sure. I think that is a misconception that I get a lot of times from family members when they call me and their loved one is in the hospital and the doctors are saying that this person, their loved one, is suffering from malnutrition. And the automatic assumption is that they're not getting enough calories, which could be the case.
Mm-hmm.
But oftentimes it's as you just described, that it's not necessarily that caloric intake has gone down. Clinical conditions of that resident have made it such that perhaps you can give them twice the amount of calories, but their body is not using the calories right, right?
Yeah, I mean, oftentimes I think too that they might not be taking in enough. That's usually part of the equation as well. I mean, if you're not feeling well, you're not hungry. So, I mean, if you think about it, when you're at home and you have the flu, the last thing you want to do is eat if you don't feel good. So, I mean, it's up to hospital staff or like a long-term care staff to check in, see if they're eating, and what can we do to improve the calorie and the protein intake that's acceptable to a family member that's in a hospital.
Does malnutrition typically present in a certain way in the elderly community or the long-term care community? Like, do we have warning signs beforehand?
Mm-hmm. So if a family member were to go in, so of course, if you notice any unintentional weight loss, that's a huge factor, but sometimes it might just be loss of muscle mass as well. You might notice, decreased appetite. Maybe foods are tasting weird if you just start asking questions. Maybe you notice them, the dry skin or real pale skin, they don't quite look like themselves. You might notice a difference in cognitive or physical function. They're not getting around as well. Maybe they have a wound that's not healing. So it might be more than just that weight loss.
If we're talking about some of the symptoms of malnutrition being weight loss, perhaps a wound is not healing as fast as it should, then I'm assuming then we're talking about days, perhaps weeks that malnutrition manifests.
Absolutely. It doesn't just happen overnight. So as I mentioned before, maybe you're on a medication, maybe you're not getting the food that you like, maybe you're having difficulty chewing. So one thing I forgot to mention, you might notice that perhaps dentures aren't fitting the way that they used to anymore. And so you're trying to wear the dentures and trying to eat, and all these things are manifesting into decreased intake over the long term. So it kind of just, it It's almost like a tumbleweed almost. It just kind of surmounts and it's worse and worse unless it's addressed.
It sounds to me from what you're describing that there are a lot of variables, and those variables will be, for lack of a better word, variable among each different person,
It's
right?
100% it's individualized. So as a dietitian, I worked in the hospital a little bit before I went into research, and I was in long-term care. And sometimes I noticed you would go into a patient's or resident's room and you would just see these oral nutrition supplements like stockpiling, or they're getting food that they didn't like. And maybe they said something to one CNA and then it didn't get communicated to the kitchen. It just, it's sometimes it's just as simple as saying, like, what are your food preferences? Are you having any trouble chewing? It's like, you're getting the chocolate Ensure, but you don't like chocolate Ensure. So it's really just talking to the resident and meeting their needs and their likes and their dislikes and seeing what's going on.
In your research, um, are you do you have a particular nutrition or malnutrition risk assessment tool that you've seen work better than others, or do you have an opinion about that?
Yeah, absolutely. So in research, we're all about definitions and using valid tools. So when a resident comes into a long-term care facility, they have to be assessed within 14 days. So a nutrition assessment or malnutrition assessment. So I'm going to kind of go into the weeds a little bit, but in nutrition, we have screening, and that's just determining if an individual is at nutrition risk. And that's real super quick, easy thing. There's usually like three questions. How's your appetite? Have you had any intentional weight loss? And there might be one or two more, but it's just a get of like, all right, does this individual need to see a dietitian? And if that's the case, if they're marked as at risk for malnutrition, then the dietitian would come in and do a full assessment. They would be looking at the medications that they're taking. They would perhaps do a physical focused exam and really look at the patient and see if there's any muscle wasting, ask about chewing, and a full assessment to determine if the patient is malnourished. And once the dietitian does their full nutrition assessment, and they would also use a valid tool. So there's things such as the mini nutritional assessment tool, the subjective global assessment tool. So the dietitian should be using some form of tool to officially diagnose malnutrition. And based on results of that assessment, the dietitian would come up with a nutrition prescription or strategies to address that specific patient to see what works best for them. So everyone would have an individualized nutrition care plan.
Now, it sounds to me what you described is that the first pass at the resident for their assessment for risk of malnutrition is by a nurse. And if the nurse flags that resident as a higher risk, then the dietitian should get involved. That would kind of be like the best practices.
Absolutely.
So, I guess this would be a dumb question based on what you've described, but if an individual is assessed as a high risk for malnutrition, then the interventions that you would put in place would vary depending on what is placing that resident at risk. But what are some of the more common interventions for somebody that, let's say that they are at risk for malnutrition because it might be mechanical reasons like dysphagia, maybe cognitive impairment. Like, what are some of the interventions for malnutrition there?
Okay. So, there's different diet textures that you could try out. So, you would change the diet order. Maybe they're just on a general diet and you would change it to mechanical soft or pureed and see if that works. Sometimes you would add on oral nutrition supplements are super common. But like I said, sometimes they get stockpiled at the bedside. So you would just work and make sure that the whoever is helping them eat. So I guess that's something else I didn't mention. They may need assistance at mealtime, like opening containers, opening, the Ensure. Perhaps it's just something as simple as making sure the Ensure is cold and giving them a straw. But just meeting their needs, these little tiny things can really help the calorie protein intake. And dietitians would, write these orders. They would talk to staff and do meal rounds and check in and see how they're doing at those meal times.
Um, Can you tell us, like, and for the audience, in the show notes, we'll link to Lisa's paper that was put out in 2024. It's Prevention and Treatment of Malnutrition in Older Adults Living in Long-Term Care or the Community, an Evidence-Based Nutrition Practical Guideline. So if you're interested in reading that, it's in the show notes. But Lisa, can you kind of walk us through kind of what brought you to this particular subject, and then we'll get into kind of the nuts and bolts of maybe your research and what you found.
Yeah, absolutely. So I work at the Academy of Nutrition Dietetics as a nutrition researcher. So we cover all topics. So where the American Diabetes Association, they strictly look at diabetes. Where at the Academy of Nutrition and Dietetics, we do our best to prioritize topics that are of importance to our members who are dietitians. And malnutrition among older adults is actually increasing, which is surprising because they can be addressed with these very feasible strategies, being seen by a dietitian and the dietitian using their strategies to improve their calorie and protein intake. So as far what brought us to our conclusion, so first we did a scoping review, like what's out there, what research is available. So when we develop guidelines, our guidelines are only as good as the existing research. If there's not research, we can't write the guidelines. Otherwise, we would be developing consensus recommendations, which are just expert opinions. Um, so based on our scoping review, where we found most of the research was on oral nutrition supplements, food fortification. So that's when you would bulk up the food. So if, say, for example, you were like to provide mashed potatoes, for example. So you rather than putting like skim milk and passing that on, you would really want to give it a boost. So you would add, lots of butter, maybe whole milk. How do we increase the calorie needs without having the patient having to increase the amount of food that you eat? Because as you get older, your appetite decreases. So that was one strategy. So the oral nutrition supplements, food fortification, and then we also looked at the dietitian's interventions in long-term care, and we were pretty bummed out not to see a lot of research there. It just wasn't available in regards to nutrition strategies and dietitians in long-term care. So we did do a call for additional research in long-term care facilities
But
in the discussion of our paper.
I don't mean to interrupt you, but I wanted to kind of understand, like, where are you getting that data? Like, are you asking the nursing homes to provide it to you, or
Oh, so when we develop guidelines, we first conduct systematic reviews. So we use primary studies that have been published. So maybe like a randomized controlled trial or an observational studies. So we take our data from studies that have already been published. So we're kind of like a secondary
I see.
research level. So
Okay.
we collect all of the research, so all of the primary studies. So, like a single trial that was conducted in Chicago or a single trial that was conducted in Boston. We try to take the best available research. We synthesize it, we summarize it, we evaluate the quality of the research, we come up with a summary, and then we write our recommendations.
I see.
Um,
Okay.
and then once we have our recommendations, that's when we start to pull in. We want to make sure that they're practical, they're feasible, we're on point. So we do like a focus group where we brought in dietitians who are working in those settings to give us feedback about, like, well, what will the dietitian need to do to implement this recommendation? So we want to make sure, we get stuck in our research world and we're just in the data and what's been published, but we want to make sure that they can be applied to real world settings.
So what are the guidelines? Like, what did you come out on the other side of the data that you got, to tell the world?
Well, we said you definitely got to get a dietitian involved. So, we might be a little biased there, but you do need a dietitian intervention. So, long term, what I've learned throughout this process, long term care facilities, you have to have a dietitian that they're not required to have a full time dietitian, but they have to either be part time, full time, or a consultant. And the dietitian, will provide, I believe, a nutrition assessment within 14 days. Sorry, this is a long answer, but it's something that I've learned to get back to. We recommended that a dietitian should see everyone in a long-term care facility. What we learned through these focus groups, it gets a little tough. And there's certified dietary managers that are in long-term care facilities, but they don't have the same skill set as dietitians do to do these full assessments and nutrition prescriptions, as I mentioned before. So that was our main recommendation. Dietitian interventions are effective in treating and preventing malnutrition in long-term care facilities. So number one, get the dietitian involved. Number two, oral nutrition supplements are a great strategy for patients in long-term care facilities. But as I mentioned, you need to check in and make sure that it's what the patient or the resident really wants
And
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 how
what
to.
and what I'm so sorry to interrupt, but
No.
what qualifies as an oral supplement that you're talking about?
Oh,
You're talking
okay.
about the Ensure, like,
Yeah, Ensure, Boost. So there's even like ones that are like juice. Like there was a Boost Freeze I remember when I was in practice, which is more like a juice rather than that milk, if that's not what the residents enjoying. So it's making sure that you're meeting their preferences because if they don't, it's only nutrition if you consume it. You could put
sure,
as many Ensures by their bedside as you want, but if they're not taking it, it's not going to help.
that's true.
So So just, you said the oral nutrition supplements, but we do reiterate in the paper, food first. We want to make sure that, first let's try to, like the meals and like what you have at home. We want to make sure they're getting a balanced diet first and then adding the supplement as needed. It's not the end all be all. We don't want to use the supplement to replace the meal by any means. It should be a supplement. So maybe in between meals, maybe they're not a big breakfast person and it should come at breakfast, but that's what the dietitian would do. Like, all right, their intake's not so great at breakfast. Let's add the Ensure at that point in time and see if we can get the foods that they like at lunch and dinner.
I see.
So that's what I mean by oral nutrition supplements. We also looked at that food fortification that I mentioned. That's another commonly used strategy. We didn't have a lot of data to support it, but it is a frequently used strategy according to the qualitative data that we got, talking to dietitians and what's generally happening in practice. And that is something too that I think that residents also prefer. If you don't enjoy the boost or the Ensure, you can bulk up the foods that they're already eating.
And forgive me, the fortification was, as you've described, adding butter or olive oil to mashed potatoes or something like that.
Yeah, exactly. So just boosting up what they're already eating, because you might already have a decreased appetite. You don't want to have to eat more food. So how can we increase the calories and the protein in the food that you're already eating?
I see. Okay. Any other takeaways?
Individualized care. So we've, the bottom line that we took away from it, there's no magic bullet. There's no one size fits all. You really need to meet the individualized needs of the residents. What foods they prefer, what times are they consuming most of the foods, how are they feeling overall about the nutrition that they're receiving. So working with the resident, sometimes if there's issues with cognitive ability, reaching out to the families and seeing what foods they prefer. So getting the dietitian involved to make sure they're, meeting the needs that they've determined in the assessment in the first place.
Very well said. Well, Lisa, we very, very much appreciate you coming on the show and sharing your knowledge with us.
Yeah, thanks so much for having me. And please let me know if you have any additional questions. We have a lot of resources at the Evidence Analysis Library with the Academy.
Fantastic. Well, folks, I hope that you found this episode educational. If you have an idea for a topic that you would like for me to discuss, please let me know. If you have an idea for a guest that you would like for me to talk to, please let me know that as well. New episodes of the Nursing Home Abuse Podcast come out every single Monday. Be sure to enter to win the coffee mug. Perhaps you like A New Hope. A New Hope, which technically was Star Wars for a long time until they remade it or retitled it Star Wars A New Hope, if we're going to get technical. Because I really need somebody to come and get all these coffee mugs. It's becoming a major strain with my relationship with my wife. Anyway, I digress. With that, folks, we'll see you next time. Thanks for tuning in to the Nursing Home Abuse Podcast. Nothing said on this podcast, either by the host or the guest, should be construed as legal or medical advice, nor is intended to create an attorney-client relationship between the host or their guest and the listener. New episodes, for now, are available every other Monday on Spotify, Apple Podcasts, or on your favorite podcast app, as well as on YouTube and our website, nursinghomeabusepodcast.com. Again, that's nursinghomeabusepodcast.com. See you next time.